Good afternoon to all. Happy to see you, ma'am, again. Uh, so today we are going to learn about gastrointestinal symptoms. Part 1, that is nausea and vomiting and constipation. This session will be taken by Dr. Vineetha Rijju, who is a palliative care physician, and also now she is pursuing MD Community Medicines at Amrita Institute of Medical Sciences, and she completed fellowship in palliative medicine from Calicut, and also she did her that MSc palliative care from Cardiff University. Has more than 5 years of experience in palliative care. Ma'am, welcome and over to you.
Thank you so much. Hi, everybody. So good afternoon, and the part of the world that you are at. Not sure of the time, but hi. So the topic for today that I'm supposed to discuss with you today is gastrointestinal symptoms. And we plan to take it in 2 sessions. The first session is going to be mainly on symptoms such as nausea, vomiting, constipation. So that's exactly what we are going to be dealing with today. Okay, so let me just share my slides. Yes, just put it on slide share now. Can you just tell me if my slides are moving?
Yes, ma'am.
Yeah?
Yes,
Okay.
yes.
Right. Yes. So coming to gastrointestinal symptom management. So I'm sure most of you are practicing, probably in palliative care, probably not in palliative care, but coming down to managing patients in palliative care or applying palliative care, it's all about the principles of how you manage the symptoms at whichever in whichever field that you are working in. So it is how you assess the symptoms and how you manage the symptoms in the best way possible, making sure that you are trying to keep up the quality of life of that patient in the due course. Okay, so tell me, let's make this an interactive session, because I usually what I try to do is that I try to get more feedback from you all, from what you have been practicing, and many of you are practicing in different areas. So it's basically a platform to share information. And knowledge is always complete when we share information. So please feel free to write down or just type or speak. You can put across your ideas on the chat box. Okay. So what are the common GI symptoms? What are the common GI symptoms that you come across in your practice? Yes? Can we use the chat box? The common GI symptoms, yes. Sumit says, Mr. Sumit says nausea, vomiting. Nishini says nausea, vomiting. Yes. Constipation as well. Liana says constipation. Yes. She also says, especially for the elderly who are on morphine. And also diarrhea. Then Mr. Oyo says nausea, vomiting. And again, Tiny says loose stools. Yes. Okay. So yes, age. Tulasi says age. Age can also be one of the reasons, isn't it? Which can give rise to GI symptoms, especially those who are bedbound and with very restricted mobility. because all this can precipitate GI symptoms. Yes, abdominal pain, age, ulcer, irritable bowel syndrome. Thank you so much for that list, Tiny. So, what is the usual way that we manage nausea? Yes, Ms. Lana was asking, what is the age? See, when it comes to age, I always say age is a number. So age is always a number, and it is a performance status of the individual that actually matters when it comes to managing a patient or probably taking a decision about what has to be decided further in terms of treatment. Always we look at the performance status of the patient rather than his age. So there is no fixed age as to after this age GI symptoms present. There's nothing like that. It is only that with age, with with aging, what happens is that there is a decrease in motility as it is of the intestines, and also there is some amount of restriction in the mobility of the individual, and also there are many who are totally bedbound. So all this could probably precipitate to GIs. And how will you manage, say, nausea vomiting? If somebody, say, let us take an elderly at the age of 75, totally bedbound. He has got hemiplegia, a weakness of the left side arm and upper limb and lower limb. So he's totally bedbound for the past 1.5 months. So, and he is having severe vomiting. So what would be that you would advise it? Like, what is the common medicines that you have seen being prescribed to manage his vomiting? Yes? Chat box? Yes, injection Perinone. Ms. Aditi says injection Perinone. Metoclopramide. Okay. Mrs. Sumit says antiemetics. Okay. Any antiemetics for that matter of fact. Okay. Yes, Ms. Anupama says injection Emised, ondansetron. Okay. Anything else? Yes, Mr. Sumit says sideline position. Put the patient lateral. Okay. Solsi says injection Emised. Yes, ondansetron again. And Mr. Sumit was saying to put him in a lateral position so that to prevent aspiration. Okay, that's very smart. And in fact, non-pharmacological methods for nausea and vomiting is also important. Yes. So why I asked you this question? Yes, Sunita was saying to avoid dairy products. So why I asked you this question? Dr. Ms. Shiny was saying, ask for history of any outside food because you want to know what the cause is. Is it some amount of, is there some cause of food poisoning over here? So this is what I want you to start thinking about. When you see a symptom, we often treat the symptom with the drug. We do not actually always get thinking to what could be the cause. So what I would like to stress here today is that in this small session of GI symptom management, we are going to understand what are the different causes of vomiting, nausea and vomiting, and that is how we are going to manage our patient with. Rather than randomly thinking of, okay, let's try give this antiemetic, let's try give that antiemetic. So there is a reason. We need to find out the cause, and accordingly, we decide on which drug we have to give. Okay. So saying that, I shall get started. Yes, so we shall see what are the common GI problems in palliative care. We shall also see how to manage nausea, vomiting, and constipation. Now, this is a case presentation. This is just a small case that I just wanted to tell you. Okay, this lady, she is 54-year-old and she has got CA stomach. She is on chemotherapy and she is admitted in the ward for urinary tract infection. And she was admitted with vomiting, abdominal colic, and fever. Now she is very tired and has admitted for completion of IV antibiotic. She has small, frequent, incomplete bowel movements for 4 days and it's also started on laxatives. She is accompanied by her younger daughter. So I just want you to read this case in your mind. And there are some questions down there. What are the issues? How will you investigate? How are you going to manage? I want you to take 1 minute to think how you are going to manage this patient and keep your thoughts to yourself because we are going to come back to this case after today's session. And what I want you to do is to see if there has been any change in the way that you thought would work best for the patient, applying what we have learned today. Okay, so have an idea what you would do for this 54-year-old lady with CA stomach, UTI, having vomiting, abdominal pain, and fever, who's on antibiotic, also having incomplete bowel movements, and is admitted in the ward and accompanied by her younger daughter. Okay. Now, coming on to vomiting, okay, it is definitely a defense mechanism of the body. It is trying to remove anything that is toxic in the body. And generally, we say emesis. There is a collective term that we use, emesis. Emesis, under emesis comes nausea, vomiting, and retching. So what is the difference between nausea and vomiting? Yes? What is the difference between nausea and vomiting? Chatbots? Oops. Yeah, I don't see any answers. So basically, in vomiting, the products are expelled out, whereas nausea is more of a feeling. Yes, Ms. Priya says that nausea is the tendency to vomit. So does Ms. Sankita say, Ms. Anupama and Ms. Anamika. All of them say that nausea is a feeling, vomiting is expelling out. Yes. So what about retching? So your patient could come to you and tell you about these 3 different things, right? So we have to manage them separately. So nausea is just an unpleasant sensation, whereas vomiting comes to forceful expulsion of the gastric contents. Retching, there is a spasmodic movement against a closed glottis. So basically, no gastric contents is coming out, but there is a heavy spasmodic kind of movement. And regurgitation is an act by which the food is brought back into the mouth without any particular diaphragmatic activity, and it kind of characterizes vomiting. So we do see a lot of regurgitation also among patients who are bedbound. And it's basically the position, the supine position, which causes more of regurgitation. Now, what could be the different types of vomiting? Will you be able to classify vomiting on the based on time? You think we will be able to classify vomiting based on time? Yeah. For patients who are taking chemotherapy, do you think that we can classify vomiting based on time, the different types of vomiting. Someone receives the chemotherapy. And what about those patients who immediately vomit? What about those patients who vomit probably after 24 hours? What do you call that term? Yes? Any answers? It's acute vomiting, delayed vomiting. So acute vomiting, which occurs few minutes to hours, and it kind of resolves after 24 hours. So, there are, as much as we know that chemotherapy drugs do cause vomiting, some chemo drugs are very much emetogenic. They have a very severe chance of causing vomiting. Whereas there are other drugs that cause vomiting, usually after 24 hours, when the patient has taken the chemotherapy and gone home. And it kind of continues for another 3 days. Okay. So when chemotherapy is being administered, they give a pre-medication. They give a pre-medication of an anti-emetic and also anti-allergics. And this anti-emetic, which is given as IV, just before the chemotherapy, helps to control the acute vomiting. But it does not have much role on the delayed vomiting. So in order to control the delayed vomiting, they are usually prescribed antiemetics on discharge from the daycare room. Right? So what is breakthrough vomiting? Yes, when you call it a breakthrough vomiting? Have you had any patients having breakthrough vomiting? Say you put the patient who is having severe vomiting on Perinom. Okay, so you have started Perinom twice daily for this patient. Now, when do you say that he has breakthrough vomiting? Vomiting even after administration of antiemetics? Yes, Mrs. Carol says that. Okay, yes, but something more to add to it? Something more to add to it? Yes, the patient is on antiemetics. Here, what happens is that the patient is on metoclopramide 3 times a day. So once he takes the metoclopramide in the morning, he does not have vomiting for about 3 to 4 hours. But after that, yes, within the time of action of the drug. So what happens is that the next dose comes only by noon time. But by then, just about 1 hour before he can take the noon dose, he starts vomiting again. This is breakthrough vomiting. Okay. And refractory vomiting. Refractory vomiting would be that you are not able to manage the vomiting despite being given the patient antiemetics, multiple antiemetics. Okay, so that is refractory when it does not respond to your drugs. Okay, and anticipatory vomiting is, can you give me an example? When does the patient when do you say that the patient has anticipatory vomiting? When do you say that the patient has anticipatory vomiting? The patient goes in for a chemotherapy for the first time, and the drug was one which had severe emetogenic potential. Okay, patient just starts vomiting right away after going home, still vomiting. In such a case, and then the vomiting comes down after, like, say, about 4 or 5 days. Okay, but before the patient has his next appointment, From the previous day evening, he starts vomiting again. The very thought of going through the chemotherapy, which causes a vomiting, induces anticipatory vomiting before his next dose of chemotherapy, even before the drug has been administered. This is called anticipatory vomiting. So what I would like to tell you here is that sometimes managing vomiting is entirely different for each of these types. The drugs that you use is different. The way you think to manage your medications is different. Okay, so yes, Ms. Kanchan says it's probably because of the stress of the chemotherapy. Yeah. And yes, so why is it important to control vomiting? Yeah, today we have divided the GI symptoms into two classes, giving one whole session for nausea and vomiting and constipation, and another session just to do malignant bowel obstruction. So why is it that we're giving so much of importance for vomiting? How is it going to affect the patient? Yes. How is vomiting going to affect the patient? Mr. Sumit says it may cause electrolyte imbalance. Yes, he's losing a lot of fluid. He's losing a lot of electrolytes. Yes, it can cause electrolyte imbalance. Yes, and Ms. Maria says dehydration. Yes, Ms. Aditi also agrees dehydration. Ms. Liana says vomiting is uncomfortable and can lead to weight loss. Yes, very much agree. Mr. Dinesh also says dehydration. Anamika says weight loss. Yes. Poor nutrition. Yes. The decreased absorption of food that happens in the process. Yes. Mr. Sumit says the patient can go so much into dehydration that the patient can go into hypovolemic shock. Yes, very true. And it even lowers the immunity. The intake of food is going to be so less that eventually it's going to lead on to a lesser immunity in the person. The patient might not be absorbing other per-oral medications if he keeps vomiting. That's an excellent answer, Liana. And Ms. Shiny also says about the dryness of skin, mouth, and oral ulcers. And that's one point I would also like to stress on. Yes, and Ms. Sunita also says it causes pain over the abdomen. Continuous frequent vomiting can also cause pain over the abdomen and chest muscles. Yes, very true. And that's one more thing I would like to add here. Yes, and Ms. Shiny also says bleeding. It can cause tear. It can cause a small mucosal tear in the esophagus, and it can cause bleeding, which we typically call it the Mallory-Weiss bleeding. And Ms. Kanchana also says restlessness. Yes, that could be also because of the electrolyte imbalances. And one more thing I would like to, bring more to your attention is that what Ms. Lina was saying, that the patient's per oral medications that he or she is having, it can be less absorbed. So what if your patient was a patient with severe pain and the patient is on pain medication? So what happens if the patient vomiting is not controlled? The pain medications are not absorbed, so your patient is vomiting and in pain as well, isn't it? So this is going to affect the compliance of your patient, right? And he might also probably refuse further definitive treatment. He might say no more of chemotherapy for me, isn't it? Yeah. So these are many reasons why it is very important to control this symptoms, because it also affects the patient's daily functioning. It's very uncomfortable. It can affect his quality of life, and it may cause non-compliance to cancer treatment, may cause refusal of effective pain medications, and also cause distress not just to the patient but also his family. Yeah. So what are the causes of nausea and vomiting? So I put a table here and I've written, I've put down the causes, again, subgroup them into like chemically induced nausea, gastric stasis, and when there is a distortion of the GI tract, serosal irritation of the GI tract, raised intracranial tension, then movement associated, anxiety induced, environmental changes. So these are all different causes for nausea and vomiting. So chemically induced nausea, what can be a reason for chemically induced nausea? Any thoughts on that? What kind of chemicals are causing the nausea? So what is that chemical which is causing the nausea in the patient? Ms. Nancy says poison. Yeah, any kind of irritant. Any kind of irritants can cause nausea and vomiting. Anything else? Anything else? What your patient could be on, which is causing the nausea? Chemo, yes. Mr. Casimiro says acid. Yeah. And Ms. Lina says the chemotherapy drug itself. Yes. And neoclassical agent, Ms. Kazita says. Can you give me an example of that neoclassical agent? Ms. Kantan? I'm not quite sure of that.
Good afternoon, ma'am. Sorry, it is writing error. I have to write.
Okay. Right. That's fine. That's fine. It always happens. Happens always to me as well. Right. So, and Mr. Ajit also says intestinal blockade. Yes, that itself, it can increase the abdominal pressure and also cause. Now, we are talking about chemically induced nausea. Okay. Chemically induced. So, like you rightly said, it can be drugs like, cytotoxic drugs like chemotherapy. It can also be opioids. Your patient is in severe pain. So the patient is probably on morphine, a strong opioid like morphine, or probably a weak opioid like tramadol. So all these can cause nausea and vomiting, isn't it? Antibiotics. Some antibiotics itself can cause nausea, vomiting, right? And also sometimes some electrolyte imbalances, like when there is a kidney failure and the blood urea levels are high, hyperuricemia, and sometimes even hypercalcemia. All these things can cause vomiting, nausea and vomiting. Okay. Now, gastric stasis. What is it in gastric stasis? What causes nausea and vomiting? Related to gastric stasis? Could there be a drug which is causing that gastric stasis? Or could it be some disease? Yes, I also get suggestions here like hyponatremia, constipation. Yes. Okay. Now, constipation is also a stasis, probably an intestinal stasis, which can lead to increased abdominal pressure, causing nausea and vomiting. Okay. So also, I would like to add that, gastric stasis can be precipitated by some drugs like opioids itself, or it can be precipitated by some anticholinergic drugs. Anticholinergic drugs like hyoscine, like we generally, the brand name that we use is Buscopan. So that is hyoscine butyl bromide is being used. That itself can cause some amount of stasis. Then the next one is distortion of the GI tract. Okay, now that is where constipation comes. Constipation, which or it can be some sort of intestinal obstruction, which is causing nausea and vomiting. Okay, and again, serosal irritation. Serosal irritation, which can cause nausea and vomiting. An example is ureteric obstruction. Okay, when there is like say some kidney stones and it is passing through the ureter, and the patient has typical abdominal severe pain in passing of that stone and vomiting also. So that can also cause. Now, irritation of the GI tract. Irritation of the GI tract can be because of drugs, Okay, the some of the common drugs like that you give for pain, the NSAIDs like Voveran, Brufen. So all these can irritate the mucosa, which can cause nausea and vomiting. What about raised intracranial pressure? So where will you see raised intracranial pressure in your patient? Where will you see raised intracranial pressure in your patients? Yes. Mrs. Sumit says in hypertension, yeah, when severe hypertensions can lead to bleeds, cerebral bleeds, yes, head injury patients. So Ms. Anupama was saying head injury patients. Sumit also says head injury. Yes, Ms. Kanchan says CVA. So all these things which cause increased pressure, intracranial pressure. Yes, Ms. Aditi and Ms. Kulvinder, all of you do agree to that. Any CVA or brain tumors or head injuries which can cause increased intracranial pressure can lead to nausea and vomiting. Yes, Mr. Jagrub also says severe headache. Yeah, like migraine. Sometimes even common migraine can cause nausea and vomiting. Now, what about movement associated? Movement associated. What happens when most of us take a nice ride on, going to hill stations? Motion sickness. Yes, motion sickness can cause nausea and vomiting. And anxiety induced, like how we were talking about anticipatory vomiting for that person who was, traumatized by the chemotherapy. Yeah, that also can be a reason. And environment. Can you tell me something about the environment? How can environment cause nausea and vomiting? Yeah. How can environment cause nausea and vomiting? Yes, the smell. Mr. Sumit was saying the smell. Nancy also agrees to smell. Yeah. So it can be any bad odor, and the patient is given food probably in the ward. And yeah, Shiny also says unpleasant odors. So probably this patient is admitted in the ward, and where, next bed in the ward, there is a colostomy which is being cleaned, and the unpleasant odor is not making the patient comfortable, and so he's not able to have the breakfast which is served to him. So and this makes him feel very nauseous, and eventually might lead to even vomiting. So all these are different reasons or causes that can lead to vomiting. Yes. So I have all everything of what we have discussed over here. The PPT will be sent to you, so you can have a read of it, of the other points that we might not have discussed. Okay. So it's not just that. There are still other reasons why a patient can have nausea and vomiting. An oral thrush, like one of you were mentioning, any mouth ulcers. Okay, so when you go to, most often this happens when we go to homes to see bedbound patients, the family tells us, oh, he has not been eating for the past few days, is just vomiting whatever we give him. And before you actually take your pen to prescribe antiemetic and take that antiemetic from your vehicle and give it to the patient, always remember to open the mouth and examine for oral candidiasis. You might see a white curdy precipitate in the oral cavity. Most probably that itself can be a cause for your patient's nausea and vomiting. So they might also have probably a esophageal candidiasis. Okay, like there is a fungal infection of the esophagus. So what happens is that you might not see actually, the curdy precipitate is very evidently on the tongue, because sometimes what happens is that in the morning the patient would have cleaned his tongue. So you might have to ask leading questions. Does he usually clean the tongue while brushing and things like that? And it can, and you can ask them typical symptoms, like, do you feel like, when you're having food, that the food is not able to clearly go through? And do you sometimes feel pain and things like that? So sometimes these can be very, very important hints which tell us that this patient is having a oral candidiasis. Okay, and halitosis. If your patient is not having a good oral hygiene, that itself can cause halitosis, bad mouth odor, which can cause nausea and vomiting. Yes, Ms. Liana was asking, which category does pregnancy fall under? Okay, so that is probably chemically induced. That is probably chemically induced because there's a hormones which is causing it is basically the hormones which is causing the vomiting, nausea and vomiting in pregnancy. Yes, and Ms. Kanti was also talking about the coated tongue. That's exactly what we were saying about the oral thrush. Yeah. And dysphagia, you ask the patient, is it very difficult to swallow? You ask for dyspepsia, and you ask for hiccups. You look for mucositis. Okay. And a difference in the taste perception, that it also can be a cause for nausea and vomiting. Okay. Right. So when you choose an antiemetic, how do you choose? Okay, you know that, okay, this patient has chemically induced nausea and vomiting. Okay, it is because this patient was started on morphine yesterday that this patient is having severe nausea and vomiting. So you want to start your antiemetic. What antiemetic do you choose? How will you want to give your antiemetic? How often do you want to give the antiemetic? Do you want to give IV? Do you want to give an oral antiemetic? How do you decide that? So first itself, the most important thing is identify what the cause is of the nausea and vomiting. Then you understand which is the pathway that is involved, which triggers the vomiting reflex. And once you are able to identify what is the cause, immediately I will show you a chart where you can understand which is the pathway that is involved, which is the receptor, neurotransmitter receptor that is involved. Then all you need to do is just match your drug to that receptor. I have another chart for that. And then you decide what is the route of administration that you want. If the patient has severe vomiting, not able to take in even a glass of water, half glass of water, then probably your patient will need a parenteral route. But if your patient is moderately tolerating fluids in small amounts, probably you can ask to have oral antiemetics itself. Okay, and that's just not what is to be done. You also have to monitor the patient, assess your patient again after 24 hours, see if your patient, or if it depends on the drug you are giving. If your drug is having action only for like 6 hours, you can even monitor your patient or assess back your patient after another 10 hours and see how good your patient is doing, whether there was any breakthrough vomiting, whether there was 100% relief of vomiting, and accordingly, you can titrate the dose. Okay. So this is the chart that I was telling you. So if your patient is having anxiety, it means that the receptors for anxiety-related vomiting lies in the cerebral cortex, the green color. Okay, now signals go from there to the vomiting center and causes vomiting. If it is any biochemical parameters, like how you were saying hypercalcemia or hyponatremia, or I would say uremia, and such kind of biochemical abnormalities can trigger the receptors in the CTZ zone, the yellow and brown zone. Okay, chemoreceptor trigger zone. And this will again send signal to the vomiting center called vomiting. Okay. And here is the same place where chemotherapy drugs also go and act. Okay. They also trigger the receptors over there. And then you have the motion sickness that we were talking about. Now, this goes and stimulates the receptors in the vestibular system. Now, raised intracranial pressure goes and stimulates the receptors in the pressure receptor. Okay. And again, we in the bottom part, we have the gut, where you have functional gastric stasis, then you have an enlarged liver or an intestinal obstruction, all these which go and stimulate the vomiting center and causes vomiting. And again, chemotherapy, radiotherapy also stimulates the receptors in the gut to cause vomiting. Okay. And the colors over here are representing what is the receptors involved. So the receptor, you can see 5-HT3 receptors, serotonin receptors, dopamine receptors, cholinergic receptors. Okay. This is not for you to get scared. This is just telling you, this chart just tells you how it basically works. Okay. There is a reason and a pathway for every vomiting to happen, and you choose your drugs according to that. Okay, you understand which is the receptor involved here. So this chart, if you can see here, has an entire list of all the antiemetics. Okay, some of them are not pure antiemetics. Some of them are also like antipsychotics. Okay, but they are all put together over here because they also have anti-emetic action. Okay. So I'm going to just skip the slide because this is for you to just understand. Okay. So when you get a copy of this PPT, you can look over it. So you can understand which drug has action on which all receptors. Okay. Now, choosing the route of your antiemetic, it depends, like I said, it depends on the condition of your patient. Oral route is the best and the easiest way. And if the vomiting is severe, you can go for any parenteral route, which can be IV, it can be subcutaneous route, or if it is severe vomiting, you can go for a continuous subcutaneous infusion. Okay. In palliative patients, mostly we prefer subcutaneous route, mostly for those patients who are bedbound, because you don't have to puncture the vein. One thing. Second thing, even IV access, because venous access might be difficult for them in such patients. So subcutaneous route is easier. Now, there is also suppositories, drug available as suppositories, antiemetics, which is available as suppositories, that can also be tried. Sublingual. There are ondansetron sublingual small patches that is available, which can be placed on the tongue or in the oral cavity, and it just melts off. It is usually given for children who are undergoing chemotherapy. And also it can be given for adults also. I was just saying because it comes in very sweet flavors like strawberry flavor. So sublingual preparations are also available. Transdermal patches are also available. Okay, transdermal patch. What is the difference between transdermal patches and topical patches? Both you apply it on the body, but what is the difference? Here I have written it as not topical patches. It is transdermal patches. So what is the difference? Yes. Transdermal and topical patches. When you say topical patch, it is applied over, say for pain, you are giving topical patch. It is applied over the area of pain where the absorption is only local. But if it is a transdermal patch, there is absorption, there is systemic absorption of the drug. There is systemic absorption of the drug into the bloodstream where it gives a centralized action. Okay. So Mr. Jagrup had also said, yeah, when we give injection tramadol to the patient, we also give antiemetic. Very true, because tramadol also has some emetic potential. It makes the patient nauseous and vomiting and cause vomiting. But one thing I would like to add is that studies have found that if you combine tramadol and ondansetron, emised, it might weaken the effect of both drugs, of tramadol's action also and ondansetron's action. Okay, so just keep that in mind next time you see a patient who is being given tramadol and emised or ondansetron together. Okay. Non-pharmacological management. So what do you do when a patient is having severe nausea and vomiting? Other than drugs, you give him a lot of fresh air, open all the windows and door, and make sure there's a lot of ventilation. And if your patient is having vestibular stimulation, give the patient a good bed rest. If it is more of oral thrush or halitosis, mucositis kind of issues, give good oropharyngeal hygiene. Nurse the patient in upright position. This is basically so that you can avoid any aspiration. And also it helps to bring down regurgitation. And avoid situations which induce nausea and vomiting. So it can be any smells, or it can be any very spicy or sour or bitter food. Okay. And suitable distractions. Distract the patient, especially chemotherapy patients. One thing that is being seen in the daycare chemotherapies is that there is TV or there are magazines available. All these as different distractive measures that is being used. And also some psychological therapies like self-hypnosis, biofeedback, all these have also been tried, but definitely we need expert hands for that. It needs training to do that. Okay, right. So now coming on to, what do you advise a patient to eat? Someone who's having nausea and vomiting. What do you advise a patient to eat? What kind of food are you going to tell to eat? Yes, chat box. Small and frequent meals. Yes, Mrs. Smith says small and frequent meals. Absolutely. Anything else you would like to add to that? Because most often what happens is that patient is vomiting, relative is the husband who is probably taking the chemotherapy is vomiting. The wife is so upset that he's not able to maintain his nutrition, provides him a big whole plate of breakfast, which he is definitely not able to take. So small frequent meals is one answer. Yes, Mr. Jagrup says semi-solid diet, which is easy to swallow. Yes. And avoid dairy food. Okay. There is no clear-cut evidence as to why they should avoid dairy food. But definitely if they are taking like curd or something, it could be better that it is not sour. That is the only thing. Then clear fluids to be given, Kanchan says. Then yes, Casimiro says avoid oily foods. Yes. Less spicy food. Yes. Mrs. Sumit says. And then Sunita says lemon juice, citric food. Now we have to be careful on when we tell them lemon juice and citric food. This might help for some, but most often what happens is that I have seen patients, I have seen many, actually, I've seen so many of them telling me, the relatives telling me, yeah, he was having severe vomiting and diarrhea, severe vomiting and nausea. So, but, we try to make sure that something goes in. So we gave a lot of fresh juice. So my next question was, what fresh juice? And easily available was orange, And most of them have told me, yeah, we gave oranges. And my very next question was, so how did you make the oranges? How much of water did you add in? And I have heard many tell me that they have given concentrated orange juice because they thought that anyway, no food is going in. So why give, diluted orange juice? Let's give it in full nutrition. But here is when you have to actually advise the family that, concentrated orange juice is very acidic, and that itself can cause nausea and vomiting, or it can aggravate the situation. Yes, cooked and boiled foods, which is easily digestible, should also be advised. Yes, Kantin says that. And yes, to Suman, to Dinesh, everybody has pitched in with their answers. Thank you so much. Yes. So small frequent meals, then most of the food try to consume in the daytime because that is better tolerated, observed to be better tolerated. And many people find that breakfast time is the best because they can at least retain much of the food when eaten at that time. And something which is easy on the stomach, like you were saying, boiled, steamed food and all that. And never cold feed a patient who is very nauseated. Cold food or at room temperature better tolerated. So sometimes even cold milk is nice. Then try to avoid fatty food, sweet food, spicy food. Avoid fiber that can also cause or aggravate the nausea and vomiting. Maybe there is a reason. Constipation could be one reason which is causing the nausea and vomiting. So giving the patient heavy meal with a lot of fiber can probably aggravate the situation. And also avoid carbonated drinks. And if the patient is having to make food by himself or herself, it would be nice at this point to ask someone to help because cooking their own food can make them nauseous. If a person is having difficulty in eating his own diabetic diet or cardiac specific diet, maybe for these few days, because they are so nauseated and vomiting, they are not able to take that bland kind of food. Maybe a few cheat days can be allowed. Okay, you can tell them, okay, since you're having severe nausea and vomiting, try to eat what you like. In moderate amounts, what you like, so that you are able to eat at least that. Okay, and definitely take tips from the dietitian. Okay. Also, give good oral care, loose-fitting clothes, fresh air, limit sound, sight, smell, which can trigger the nausea and vomiting. Also, contact information if the vomiting is not controlled well enough. Okay. Now, coming on to the management guidelines. The management guidelines for nausea and vomiting. Now you have to document, you have to make a proper assessment of the symptom, find out what exactly the cause is by a good history taking, and also see if the cause, once you know what the cause is, you can understand whether the reason for the vomiting is reversible or irreversible. So if it is a drug like morphine, which had caused the vomiting, you know that if you can probably add an antiemetic, or even if after adding antiemetic, the vomiting is not come down, you can even probably think of changing the drug. Okay, that is for uncontrollable cases, refractory cases. Okay, you may even think of changing the drug. Now that is a reversible cause. Okay, you know the trigger factor, you can reverse it. How about for other causes, which is not reversible? There is a total obstruction of the gastric outlet that you cannot do. You cannot reverse it by just giving antiemetic. Okay, so potentially reversible causes like drugs, constipation, severe pain, infection, cough, all these are reversible. So treat the cause, and thereby manage the nausea and vomiting. Okay, review the dose after 24 hours. If nausea and vomiting persists after 24 hours, you again review the cause. Maybe there are 2 or 3 causes which is causing the nausea and vomiting. So you have to address each and every cause. Okay. Then remember, 1/3 of the patients will need more than one antiemetic. If on parenteral, consider converting to oral after 72 hours of good control to oral regimen. So if the patient is on IV drugs, that can be continued until the patient gets good control. Once there is good control, switch over to oral regimen and continue the patient on oral regimen till you make sure that the patient is completely comfortable. So if your patient is admitted and you put the patient on IV drugs, it does not mean that the nausea and vomiting is controlled and you stop the drug and you send the patient home. No, it doesn't work that way. It has stopped because you have put the patient on IV drug. So before the patient gets discharged, you make the switch, see how he is tolerating the dose, and with that dose, you send him home and ask him to continue that dose for another 3 days and then slowly taper and see how he does. Okay, these are the different drugs that we use, and this is just the classification under which the drugs are written. So hyoscine, you can see the first one, anticholinergic. What it does is that it brings down the secretion. It is an anti-secretory agent. It is also an antispasmodic agent. Okay, it brings down the spasm of the gut. It also brings down the secretion. Okay, so thus it helps to control the vomiting. Okay, and also drugs like prokinetic drugs, metoclopramide, domperidone, they induce the forward action of the gut. Okay, and that helps to bring down the vomiting. Okay, aprepit, the NK1 receptor antagonist. This is specifically for anticipatory vomiting. You usually prescribe aprepitant for such patients. And then most commonly, the 5-HT3 antagonist, you have the ondansetron, granusetron, palanositron. All these group of drugs, they are all centrally acting drugs. They all act on the vomiting center directly and inhibit vomiting. And then you can see on the side, the adjuvant antiemetics. These are steroids, dexamethasone. You have a muscle relaxant, a short-acting muscle relaxant like benzodiazepine, something like lorazepam or midazolam. All these things can be given for patients who also have anticipatory vomiting. Okay. So these are some of the drugs. So if your patient is having opioid-induced vomiting, nausea, vomiting, ideal drug would be haloperidol. You can start off at 1.5 milligram to 5 milligram per day, or and give per oral or subcutaneously or IV. Okay, and metoclopramide, again, you can start off at 10 milligram, and it can be given about 6 hourly or maybe as frequent as 2 hourly or 4th hourly. Okay, and that also orally, subcutaneous or IV, as and how the patient will tolerate. And always be careful when you are giving parenteral metoclopramide, because sometimes some patients can show extrapyramidal symptoms with metoclopramide. So just keep a watch on it. And if you have seen one patient who has developed extrapyramidal symptoms, you will never forget it. I have seen 2, and 2 bad ones. So I will never forget it. Every time I look to the, I go through this slide, I, without fail, always try to mention about the extrapyramidal symptoms of metoclopramide. Then domperidone, ondansetron, cisapride, prochlorperazine, diphenhydramine, and all these are commonly used drugs which we can try for vomiting. Okay, and generally octreotide, which is given over here, it is again an anti-secretory. Okay, anti-secretory agent, like how I was telling you about hyoscine butyl bromide. Now, hyoscine butyl bromide, that is buscopan, should not be combined with metoclopramide, because it will antagonize each other's action. It will nullify the action of each other. Okay. Then dexamethasone. Okay. Also, we said it can be given, right? Now, constipation. Coming on to constipation. When will you tell that a patient is constipated? When will you tell that a patient is constipated? You are going to see, a patient has come to you and telling you that now I've been very constipated. What is the next thing you will ask them? You want to know whether it is actually a constipation. What is it that you are going to ask them? Yes, you ask about food intake. Okay. You want to find out whether it is exactly a constipation. Yes. When was your last bowel movement? When was the last time that the stool was passed? Yes, Ms. Laina and Mr. Sumit. Yes, thank you for that. Yes. These things are going to tell you, differentiate it from whether it is actually a constipation. Okay. What we need to understand here is that when was, actually speaking, you need to understand when was the last time you passed your bowels and how often do you pass bowels on a normal basis. So maybe the patient has not passed his bowels the previous day, but if you ask him, but how is your normal bowel pattern? He might say that, well, I pass bowels, I open my bowels every 3 days. So then it is not a constipation. It has to be different from his normal routine. Okay. And so difficult or painful defecation is also associated with infrequent bowel evacuations and hard feces is when we call it a constipation. Okay. And always ask how different is it from your normal. And 45% of palliative care patients are constipated. So what do they complain with? They say they have an incomplete evacuation feeling. They have a very bloated feeling. They might say that they're very nauseous, having vomiting, or they have severe abdominal cramps. Or they might say they're having overflow diarrhea. Now, this is a very, very common thing that we see. And the patient might come and tell you, I am never going to have that laxative again because I just had very little. Or, they might just say that, I'm just passing stools continuously. So one important thing at this point of time that you have to ask, that to know if it is actually a diarrhea, you have to ask them that same question. When was the last time you had a normal bowel? So for all you know, they might probably tell you, oh, I have not passed bowels for the past 6 days. But since yesterday, I've been passing small, continuously, small amounts of dribbling rather. And it is very irritating. So at this point, you should understand that this is overflow diarrhea. This is overflow diarrhea. And this diarrhea has happened not because it is a proper diarrhea. This is a constipation that you're looking at. So overflow diarrhea is a sequelae of constipation. So when the fecal matter is sitting in the intestine for a longer period of time, what happens is that the upper part of the fecal matter starts to necrose and liquefy. Now, over a period of time, this liquefied matter, it dribbles around the side of the intestinal wall and comes out. And this is what the patient tells to you as diarrhea. So you need to treat it not like a diarrhea, but you need to treat it as a constipation. Okay. So the first and foremost thing, if you just do a per rectal examination, a digital examination, you will see hard feces in the anal area, in the rectal area. Okay, so that is how you treat overflow diarrhea. You have to manually evacuate the hard fecal mass and you have to give the enema. Okay, now this itself, because the rectum is loaded with fecal matter, this can cause back pressure on the bladder and cause urinary retention. So these are all different symptoms that the patient will tell you if they're having a severe constipation. Okay. Yes. So Kanchan also says about frequent intake of liquid. We have to go for bowel movement and impact stools. Okay, the type of stools, days without bowel movements. Thank you so much for all these inputs, Casimira, Sunita, and Kanchan. Thank you for that. Yes. So what do? We have a lot of causes for this. We need to understand what is the cause for the constipation. It can be pharmacological. It can be your drugs which is causing the constipation. So if it is your drugs that is causing the constipation, it is reversible. So you have a chance to tweak your drugs, to make adjustments in your drugs so that you can relieve the patient's constipation. Okay, so these are some of the drugs that I have given, which can cause constipation. Then metabolic causes like dehydration, hypercalcemia, hypokalemia, uremia, all this can cause constipation. So correction of these can itself bring down the constipation. And definitely you have to combine it along with laxative. Now diet, again, like you rightly said, low fluid diet, high fiber content, poor appetite, less intake of food, all this can be reasons for the constipation. Environment. What if this patient is hospitalized in the ward, unable to get up from the bed and go to the washroom? So maybe a commode, a stool is kept near the bed of the patient, and the patient is having to go open his bowels in the middle of the ward. Will he be able to do that? So will you call him constipated just for that reason? It is because of the hospitalization, because of the environmental conditions, which has triggered constipation in him. Okay. So there is also issue of inability to attend to call. There is no bystanders in the house to take him to the washroom. All this can also lead to prolonged constipation. Now, neurological causes, like probably it's a spinal cord compression, paraplegic patients, quadriplegic patients, all these patients also can have constipation. Or maybe it's some tumor sitting in the pelvis, okay? Or this patient has had radiotherapy for that. All this, or maybe, there was so much of hard fecal matter that when the patient was trying to pass motion, it caused tears in the anal area. And these tears started paining so much that every time he tried to put pressure to pass motion, the anal orifice would extend and stretch rather, and this would cause more pain. And this itself would aggravate the constipation, right? And also other conditions like depression, weakness, immobility, inactivity, old age, all this can contribute to constipation. So you assess the patient correctly, what is normal for him, understand what is the frequency of the stool, the amount of the stool, whether it is blood stained, yes, no, when was the last bowel movement, is he having any abdominal pain, vomiting, crampiness, or gas, or does he pass flatus? Like, is he passing gas? Okay. Does the patient regularly use laxatives? What if the patient is on laxatives? So, what? Also, another thing is that these patients, they tell you, doctor or sister, I am taking laxatives, but still I am not passing motion. Find out from them how much of laxatives they are taking. For all you know, they probably are not taking the adequate amount. So that itself, underdosing the laxatives itself is the reason why most patients have constipation, despite being on laxatives. What medications are the patient on? Try to find out that, because those drugs itself can be causing the constipation. And is the constipation a recent change, or what is the type of diet of the patient? All these are important. Now, the common issues that you find among relatives is that them telling you, oh, he has not eaten enough at all. So then how is he going to pass motion? This is one thing that many of the family members tell us. But that is not true. You must tell them that even if they have not eaten, there is intestinal secretion that is present, which can form fecal mass. Okay. And again, when someone tells that I have diarrhea, try to find out whether it is actually a diarrhea or a overflow diarrhea, because the management is so different. Okay. Yes. And how do you manage? Correct the correctable causes. Find out if it is reversible causes. Then correct that cause. Okay. Then you also give judicious use of laxatives and improve the general condition of the patient. And symptom control is given. Encourage activity for the patient and control the fiber diet of the patient. Okay. Non-pharmacological management, access and ability to go to the toilet, timing and privacy. Squatting position often helps to have a better bowel movement, and encourage plenty of water and normal balanced diet, like you just mentioned right now. Okay. And how do you manage? Rectal examination, proper use of right laxatives, suppository, and proctolysis, or you can give an enema. Okay. And digital evacuation and fecal impaction. That is very important. Okay. Most of us may think that, oh, this is interrupting the privacy of the patient, doing a digital examination, asking the patient to turn around and do a per rectal examination, but it is very important. It gives you a lot of clue on what is the reason for the constipation, or probably what is the reason for the overflow diarrhea, or what is the reason for the retention of urine. Okay. So those patients with frequent constipation leading to retention of urine can develop frequent urinary infections also, because there is always some amount of residual urine that is left behind because of the back pressure. Okay. So the different type of laxatives, you have bulk forming laxatives. So it increases the bulk of the fecal mass, and that itself stimulating the forward action of the fecal mass and evacuation. Also, there is lubricating oils, which helps to facilitate the motion, or maybe osmotic laxatives like lactulose, milk of magnesia, or PEG, which we give. Stimulants, most often we give stimulant laxatives with morphine tablets. That is, we use bisacodyl mostly. And stool softeners also can be used, like docusate sodium. Okay. And most of your paraplegic patients might need regular laxatives, or they might need manual evacuation. And colostomy patients also can get constipated, and you treat it the same way like how we discussed right now. Okay. Yes, I'm just going to run through this because we are very much in short of time. Manual evacuation, please read through the slide on how it has to be done. Always give a lot of respect for the patient. Tell them what you're going to do, and do the digital examination per rectal very gently. Okay, talk to the patient as you're doing. And now coming to this case, 54-year-old lady with CA stomach on chemotherapy and urinary tract infection is having vomiting, abdominal colic, fever, and is on antibiotic. Also having incomplete bowel movement, and is already on laxative, and is accompanied by her younger daughter. So what is the issue here? So please tell me what is the issue here. Please look at the clues which is given in red and blue. What is the reason for the vomiting over here? Yes? Reasons for the vomiting? Quick one.
It can antibiotic.
Yeah, it can be the antibiotic, the chemical induced. Nancy also says the chemotherapy probably caused it. What else? What else is here? The constipation, yes. Shiny was saying constipation. Liana was saying the urinary infection. Yes, urinary infection is known to cause vomiting and joint pains. Yes. Yes, Mr. Dinesh, Pricey, everybody agrees to that. That the urinary infection could also be the cause here. So the cause is being looked into. Antibiotics is being given to treat that reversible cause for the vomiting. Yeah. And also the incomplete bowel movement. Probably constipation is also aggravating the vomiting. So giving proper laxatives and adjusting the dose of the laxatives is also going to help. Another clue over here, if you look, is that she's been admitted in the general ward. And who is there to help her? Her younger daughter. So how much is the younger daughter able to take her to the washroom in the ward? Or is she being made to, she's given a bedpan or something and asked to pass bowels in the bed itself? We are not sure. Okay, so all these can be different reasons which is leading on to that. Yes, and Casimiro also says it would be probably an obstruction for all you know. Yes, thank you. So this is how the X-ray was looking. Oops. Yeah, this is how an X-ray would look for someone who has a loaded bowel, and you can know that the person is being constipated. You can see the fecal mass on the side. You can see the fecal mass on the side. Yeah, this is the fecal mass on the side. And here there is another case who's a quadriplegic who's given feeds to the nasogastric tube. He's presented with vomiting in 2 days and sick. And what is the reason? Somebody who's having a Ryle's tube and is vomiting. What could be the reason? Cholecystitis? Somebody who is having a Ryle's tube and is vomiting. Yes. What are the reasons? Infection. Okay. Something else? The most important two causes? Someone with a Ryle's tube, an nasogastric tube, and is vomiting. It can be a block of the tube, okay, or it can be a block of the tube, or it can be maybe the relative is overfeeding the patient, okay, and he's probably sick because he's aspirated and he's developed pneumonia or something. So to summarize, you evaluate, manage, monitor, assure, and you manage by correcting the correctable, non-pharmacological management, pharmacological management, and also intervention when needed. And also do not forget, you please also look at the psychological, spiritual, functional factors also of the patient, which could be aggravating the vomiting of the patient. Because only if you treat the patient as a whole, will you be able to give him a good control of symptom and a quality of life. Yes. So I am sorry because I have exceeded the time. I think we should soon get into the presentation.
Thank you, ma'am, for the excellent presentation. We have a case presentation. Bindu will be presenting a patient story today. Bindu,
yeah,
so to you. In the meantime, if you have any questions, please put it in the chat box. After that, we will.
Bindu ma'am, are you there?
Hello, madam.
Yes, we can hear you.
Madam, എന്റെ ഫോണിലെ ചെറിയൊരു പ്രശ്നമുണ്ട്, നെറ്റ്വർക്ക് പ്രോബ്ലം ആണ്.
Okay.
ഞാൻ സിസ്റ്ററുടെ അതിനാണ് പ്രസന്റ് ചെയ്യുന്നത്.
കുഴപ്പമില്ല, പ്രസന്റ് ചെയ്തോളൂ. Can you able to see the slides?
കാണുന്നില്ല.
Yes, we can see the first one. ഒന്ന് അടുത്ത slide ഇടാവോ? It is changing.
Bindu.
Madam.
Can you see the slides now?
കാണുന്നുണ്ട്.
Okay, present ചെയ്തോളൂ.
My name is Bindu, working in EMS Hospital, Pindalmanna. My patient name is 85 years old, male patient, diagnosis stomach cancer. Presenting complaints, general weakness, vomiting following chemotherapy, feeling of fullness, dysphagia. History of illness, 85 years old, male patient, onset of disease, April. Mode, vomiting, tiredness, dysphagia since 5 months. Personal history, no history of non-diabetes and hypertension. Family history, no history of malignancy in family. Examination, physical examination, height 162 centimeter, weight 50 kg, thin, built and undernourished, febrile, heart rate 76 per minute, respiration 22, BP 110, 80 mmHg, SpO2 99% at room air. Treatment and significant investigation. Endoscopy, linear ulceration seen at the lower esophagus, stomach, large nodular circumferential ulcerated growth seen at the antrum and body extended to increase. Biopsy taken concluded status esophagitis and CA stomach with a partial gastric obstruction, outlet obstruction. CT wall abdomen, concentric bowel and bowel with a thickening noted in the distal body of stomach and antrum with a mild pedigastric lymph nodes noted. Blood chemistry HB 11.5, WBC 15.8, ESR 70 mm per hour. Treatment chemotherapy. Medication, injection Ondion 2 mg, injection Dexona 16 mg, injection Raso 40 mg in 100 ml NS over 20 minutes, injection oxaliplatin 150 mg IV in D5 500 ml over 3 hours, 100 ml NS IV stat. Tab Tramadol TID, tab Capitro 500 mg 2 BD, cap 2 OD, protein powder. Psychosocial aspects. He has 3 children, 2 male, 1 female. All are married. He lives with his elder son. His son is the breadwinner of his family and he is a teacher. He needs a supportive system for further treatment. Main concern, prevent further metastasis of disease, improve the nutritional status, management of side effects of chemotherapy, regular follow-up. Summary, 85 years old male patient with CA stomach and now admitted with the complaint of general weakness, vomiting, tiredness following chemotherapy. Now patient is better and discharged on September 10. Discussion points, pain management, prevent further metastasis, nutritional buildup, individual counseling, family counseling.
Thank you, Bindu, for the presentation. Anybody need any more clarification regarding this patient story? Please ask that. Otherwise, we can move on to the discussion points. So I hope this presentation is clear to everyone. So we can move on to the discussion points. Ma'am, over to you. So we had a wonderful session. Anyway, you will try to answer these questions. You can also contribute some. So we would like to hear from you all. So what you will, if you have seen these kind of patients in your settings? How will you manage?
Yeah, thank you. Thank you, Bindu. It's a nice case, and you presented well. So the case is now open for discussion. So we have here a 85-year-old lady with CA stomach, locally advanced CA stomach. Okay, she is having locally advanced CA stomach at the age of 85. She has been advised to take chemotherapy, one IV chemotherapy, oxaliplatin, and one oral chemotherapy, capecitabine. So these are two things that she is taking. Now she has developed vomiting and weakness, and she's been admitted to the hospital. So why do you think she has developed vomiting and weakness? Yes, what is the cause over here for vomiting? Cause over here for vomiting? Chat box, or you may speak. Due to chemo. Yes, Nancy says due to chemo. Yeah. Yes, Dinesh, everybody, I think everybody agrees to that. And Kanchan says that it could be because of the environment. Yeah, that's one extra answer that we've got. Otherwise, I think everybody, Tracy, everybody says that it could be the chemo induced, right? Casimiro, everybody says that. And Bindu also says, Suman also says. Yes, definitely, oxaliplatin chemotherapy is known to cause vomiting in patients. And as you can see here, high dose of dexamethasone was also given as a pre-medication for the chemotherapy. And along with that, the patient is given oral chemotherapy, capecitabine. And you know, capecitabine is given for 14 days. For 14 days. So the 14 days, patient has to have 2 tablets in the morning, 2 tablets in the evening, and they are huge capsules. So this itself can cause vomiting, okay, and gastric upset. So now with all this vomiting, the weakness is probably because of yes, the weakness is probably because of poor nutrition. Yes, Kanchan says it's probably because of poor nutrition, because of the vomiting. She was not able to eat anything, or probably also because of any other reasons. Maybe the electrolyte imbalance. Yes, definitely. Bindu also agrees to that. Yes, the dehydration. Tracy was saying with the dehydration. Yes, Carol Chicker was talking about the loss of appetite secondary to the nausea and vomiting. Yes, there's so many reasons, isn't it? So all this could be contributing to the nausea and vomiting. And again, the disease. We have forgotten about it. It is a partial obstruction that you see of the gastric cavity. The stomach itself, the gastric outlet itself, there is a partial obstruction. There is a very little space for the food to go through. So that itself can be causing fullness, vomiting, and with all this vomiting, electrolyte imbalance and weakness. So what can you do to reverse it? The disease, anyway, the chemo is going to act and reverse it. Over time, nothing very magical that is going to happen over a day. So otherwise, the weakness, how about the weakness? Weakness with IV fluids, because you said dehydration. Probably if you check the investigation, some parameters, okay, probably the electrolytes can, whichever can be replaced, supplements can be given. Okay. Then you were talking about the pain. One of the concerns, I mean, the discussion points you wanted was probably regarding her pain. But did she have so much of pain? I thought you had somewhere commented of pain score of 3 on 10. Am I correct? Can you just go back to that? Was she having more pain than that? Or was it on tramadol that she was having pain of more than, a pain score of Did I see somewhere 3 on 10? No? Bindu, did she have a pain score?
Madam.
Any pain score undairunno? Etra pain undennu?
3 undairunnu, madam. 3
3
out of 10.
Yeah. Okay. Okay. So now one thing more we need to understand is that she was having a pain score of 3. Okay. A pain score of 3. Now for a pain score of 3, I would say it is a mild pain. So do you actually require something like tramadol, which is a weak opioid that that is supposedly supposed to be given for a moderate pain? Because tramadol itself can cause nausea and vomiting. It's going to aggravate the symptom of the patient. So you can bring down your analgesic to paracetamol. You can come down the ladder and you can put the patient on paracetamol, which does not have a emetic potential. Okay. Now, what is your next question for discussion?
Paracetamol IV.
Yeah, if severe vomiting, then paracetamol IV. Otherwise, you can put the patient after tolerating on tablets. Okay. Then the next discussion point, can I have a look at it? The last slide. Yeah. Preventing further metastasis. So I would like the team to tell me what they think about preventing further metastasis. Yeah. Yes. Are we actually concerned about preventing further metastasis? What do you all suggest? Can we have the answers in the chat box? Yes, Nancy says a regular follow-up would do. Okay, a regular follow-up would help to see if she is having any further metastasis. Yes, Tracy also agrees to that. Okay. So what I would like to add here is that, well, she's having a locally advanced disease at the age of 85 and she's already been started on an aggressive regimen chemotherapy. So which should probably do some good in controlling her disease. So I think in a palliative perspective, let us be more focusing on the symptoms. Okay. Let us be more focusing on the symptoms, because considering how much of time she has left, what is her survival going to be? Let us manage her symptoms more, because we may not have much to do regarding her metastasis from a palliative perspective of view. But if her disease does progress, we can definitely change our management according to that. Okay. Nutritional buildup. So what are you going to advise her regarding nutritional buildup? Nutritional buildup? Yes. What kind of food are we going to ask her to eat? Yes. Has everybody left? I don't see any answers. Okay. Tracy says protein-rich diet. Carol says soft foods. Yes, Nancy says small frequent meals. Yes, all of you are right. We ask her to have soft foods, small frequent meals, protein-rich diet, absolutely. And also less spice and almost bland food, semi-solid. And yes, Casimiro tells to refer her to the medical nutritionist. Your modified diet has to attend to her needs, absolutely. If you have facility for that, that would be the best thing. And Bindu also says a balanced diet should be given for her. Yes, very true. Yes, bland diet, and clear fluids like Holacey and Kanchan were saying. Very true. So these are all the recommendations we are going to tell her regarding her nutritional diet, especially the proteins, because cancer, cachexia, there is a lot of muscle loss. She is very poorly nourished. So a lot of protein is very essential for her. Okay. individual counseling and family counseling. So, what kind of counseling will she require? She and the family require. Your thoughts on that? That is our last discussion point. Individual counseling and family counseling. What kind of counseling should we give her? Yes? Can we have few answers on the chat box? Or if you want to talk about it? Yes, Ms. Malini was talking about the family counseling. Yes, regarding the status of the disease. Yes, we have to keep them well informed of what is the current status of the disease. I agree. Yes, what else? The patient and the family need to know what exactly is the status of the disease. Yes. Regarding the expected outcomes, yes, Mr. Sumit says yes. The patient and the family need to know what is the expected outcome of the disease. You have to respect the right of the patient to know what is happening with her. The financial expenses, yes, the family is the caregiver. Okay, if the family is a caregiver, yes, the family is a caregiver here, I guess. So Kanchan also talked about the financial expenses. If they do not have the financial expenses for the treatment, we have to connect them to organization, NGOs, where they can also get help from. Okay. And yes, also the spiritual need. And yes, Mr. Dinesh was talking about the side effects of the chemotherapy, right? Yes, spiritual needs also is very important. We need to address the spiritual issues of problems of the patient and give her the support according to that. And again, another important aspect is what to expect as a side effects of the chemotherapy. Okay. Now, having a drug like oxaliplatin and capecitabine, one side effect which is bound to happen is peripheral neuropathy. It's almost sure and bound to happen, peripheral neuropathy. So she might start losing sensations over the peripheries. And you have to tell her not to kind of, rub her hand and wash it hardly with soap, like just mildly, just dab it. And even the leg, not to with pressure kind of rub the feet on the floor or anything. And also that she is bound to develop oral ulcers and oral candidiasis. So good oral hygiene is very important. And also that she might develop distaste of the mouth. So that can also be a reason for nausea, vomiting, things like that. These are all side effects of the chemotherapy. And again, capecitabine is a drug which can cause diarrhea in patients. So when she is taking her laxatives, also ask her to keep this in mind. Okay. Then again, if she is having pain on swallowing, we can advise her drugs according to that, like, sucralfate or something, sucralfate with xylocaine gel, like Nucaine gel or something, so that she gets good relief of pain. And also, because she's taking chemotherapy, we have to also tell her about the probability of getting neutropenia and neutropenic sepsis, where the counts fall down after chemotherapy, and she can develop infection, she can develop severe weakness. So we do not know whether this hospitalization that she came with weakness and all that was because of also neutropenia. Okay, so these are all different reasons. Anything more that any of you would like to ask? Yes. I think we have had a fair amount of discussion, and everybody is kind of saturated.
Okay. So I think no more questions. Maybe we can wind up the session. Time up. So thank you, ma'am, for the wonderful interactive sessions. I hope that this session they have is very helpful for them. They will